Okay, so I'm going to get started again. That was a really good video that we saw. So yeah, it covered all the points that we were discussing before, and the demonstration of cord packing was also pretty good. And if you get a chance, you can see the video a couple of times because this is what we're going to do when we meet for the lab exercises as well. There's a little bit of a learning curve that is there when we are doing cord packing, and just give it some time, and I'm sure you guys will get the hang of it and become pretty good at it. Okay, so again, if you see this slide that we were seeing before we started the video, there's the angulation of the instrument. If you see, it's going at an angle and it's not going completely like vertical, right? So that has to be lateral and not apical pressure. And it's like tucking something in. So we can go over that when we need to. All right, so the tissue retraction. So this diagram is really good because it shows the way if you pack one cord, there's poor access, the tissue is collapsed, versus if you pack two cords, especially if the smaller cord goes in first, so then that also helps in a way that it stops the sulcus bleeding. And the bigger cord, it creates like a V-shaped opening so that we can see the 0.5 millimeters beyond the finished prep, and it allows for access of the emergence profile for the crown to be fabricated. So cord is packed into the sulcus, it displaces the gingiva, controls the bleeding. And where do we overlap the cord? So typically you just do it in the interproximal area. Reason being that it's the thickest part of the gingiva, so it can take a little bit more pressure versus the buccal or lingual sides. Okay, so these are the CompreCap uh, tissue pressure caps, and I really like using this after the cord is placed. It helps displace the tissue while absorbing fluids and pressure hemostasis. It lets you, also gives you some time when you have to get ready for the tray and then putting the material in, so helps maintain the dry field, um, while just before taking the impression. So in the next couple of slides, we're going to talk about epinephrine reaction. So what happens if we are using the epinephrine cord, impregnated cords? So the signs of an epinephrine reaction is increase in cardiac rate. So there will be tachycardia, and the heart will start working more. So the force of cardiac contraction increases. The patient can hyperventilate and suddenly just feel anxious or stressed. And if the patient doesn't know what's going on, then it's just comes as a big surprise too. So that the psychological factor is also pretty intense for some patients. And also depends on their personality, right? Some patients have a lot of anxiety and for dental treatment in general. So it's very important, like whenever, even if I'm giving local anesthetic that has epinephrine, I just let the patient know that, the kind of feeling that you get if the traffic light suddenly turns red, or there's a car in front of you, so just like a jerk. That's the kind of feeling it's kind of considered to be normal. So if the patient expects it, and if he feels, no, this is a little bit more than that, so you can let us know. So it's good to just inform them beforehand so they can be prepared for it. And that avoids the confusion that a patient can be happening, that what is going on, what suddenly happened, right? Because the whole procedure they're kind of doing okay, and suddenly this jolt that they feel, right? So, and yeah, at later time it almost has like a post-traumatic effect that, oh, that wasn't a good experience, I don't think I want to go back to getting a crown done again. So sometimes I see patients who have done these big procedures in the past and then say they need one now, and I can see them, the recall, they're coming again and again, they're getting their fillings done, but if it's come down to a crown, they just want to avoid it. Significance and treatment of epinephrine reaction. So if there's a patient who has is a healthy patient, has no cardiac problems in the past, then for them, it's just a exaggerated physiologic response to the drug, and it's not life-threatening. And it's also that mental trauma that can happen, that, oh, this wasn't a good experience for me. So how would you treat that? You just calm the patient down, you seat them up. I typically ask, do you need a glass of water? Do you need a restroom break? And that kind of helps them calm down. And once that happens, you just remove the cord, you stay with them, give them a couple of minutes, and reassure them that no, everything is fine. This is almost something that can happen every once in a while, and it's normal. And just monitor their blood pressure and pulse at intervals. So if they say it's a little bit high right after this happens, then give them a couple minutes to settle down and check it again after 5 or 10 minutes. It's better to reschedule the appointment. It also just consider the patient. Like if they think they can go on, you might want to maybe just make sure that they're okay and start again. But if possible, I think the best thing is to just reschedule. Sometimes time is a factor for the patients. They can't come in again and again, but if they can, then we should try and reschedule. Now, if the patient has cardiac insufficiency or hypertension, number one is I have no idea why they would be using the epinephrine on that patient. There are so many other alternatives which are equally good. But what do we do if this happens, right? So it's just a hypothetical situation. It could be life-threatening if the cardiac reserve is exceeded by the effects of the epinephrine. This is pretty rare, but it's definitely a possibility. And how would you treat it? You just have to think that this is a medical emergency, and all our BLS training will come into use here. We call 911, we designate somebody to get the AED. Just be prepared for everything. And yeah, just treat it as an emergency, and sending the patient to the hospital is the best thing. And of course, do not use epinephrine with these patients. Why do you want to come to this situation if you can totally avoid it? Okay, so now we're going to the next part of the presentation, in which we'll talk about how do we take the impression. So the cord has been packed, we've maintained a dry field, everything looks good. So we come to the next part now. Okay, so what is the first thing that you have to take care of? Sorry, I just wanted to pause for just a quick second. I have my speaker notes, which I forgot to reopen, so I just want to make sure I'm not missing out on any points. Don't know whether this is recording or not, but I'll have a background noise just in case it is. Okay. Sorry about the interruption. I'm gonna start talking about the okay. So impression technique. First thing is really the mindset that you're going to work with while you're taking the impression. You have to be confident, and you have to think that, okay, I'm going to get this in the first shot. Don't assume that you're going to need a retake. Take your time. Just mentally prepare for the procedure. What are you going to need? What are you going to do? Try in the tray. Make sure assistant is available if you're going to need help with the impression, and know when to reschedule, right? That's really, really important. Like if you see there's a lot of bleeding and it's going to take a long time to control the bleeding, you want to just let the patient know that it's for their benefit, that we don't want to complete the impression today. Let their gums heal. That's the most important thing. And they're typically understanding about it. Another reason why you might want to reschedule is if you see that patient is in a bit of a hurry to leave and they have an appointment, or you are really going late in schedule that day, it's okay to reschedule. Initially, I used to think, no, I have to complete the appointment the day off, but it's not. It's important that it's more important that the impression is done nicely. Um, okay. So addition reaction silicones, they are hydrophobic. So again, the moisture control is really important. You have to make sure that the tooth is completely dry and the sulcus is dry. Of course, the residual water needs to be cleared with the air water syringe. And when you look at the area, it should look dry. A syringe really helps. And if the isolite is there, then make sure you just take it out just before the impression is to be taken, so the dry field is maintained. Okay, so good idea to use nitrile gloves and avoid latex glove when you're using addition silicone, because it can retard the setting reaction. And say you think that the impression is taken and then the light body is it sometimes takes a little bit longer to set. So you have to make sure that if just the heavy body feels like it's set, you want to wait a couple of minutes before taking out the impression. And wash the gloves to remove powder. Avoid touching if you don't have the option of nitrile gloves. Then make sure that the sulfur part of the latex glove is not contaminating your impression. Okay, impression tray techniques, tray stability. So when you are placing the impression in the patient's mouth, the very important thing to do is that you hold the impression for the entire 5 to 6 minutes that it's going to take for the impression material to set. Typically, I've seen that the doctors, they start doing some other work, writing their notes, or even the assistants. So that's something that you cannot take a chance with, because if the tray moves or the patient moves even like by a little second and the impression is not set, then we will have a situation where the crown is ready and it's not the correct size because of the distortion. So that will bring you back to redoing the impression and redoing the crown. So it's good to spend the extra few minutes with the patient and make sure that the impression doesn't get distorted. Okay, so before we start taking the impression, you have to verify that the patient can close into centric occlusion, because if they cannot, if their centric occlusion bite is not repeatable, then using the double bite tray technique will not help. You have to use one of the stock trays and take an impression, and then do the Facebook transfer ideally, and go that route. And then I always try to visualize a landmark for seating the actual impression. So say I'm doing a second premolar. So I prefer to use the longer tray, and say the tray ends somewhere mid canine or something. So I try to remember that landmark, that when I'm placing the tray. So the two things, a couple of things that are most important is that you have to make sure that the tray is in the center mesiolingually, and posteriorly. When the patient bites down, they don't bite down on the tray itself, because then you will not get the maximum intercuspation that you should when you're doing the double bite tray impression. So and then I always take a separate bite, and Regisil is a good brand to use if necessary. And okay, so yeah, just make sure once you do this, it makes it very helpful to get a good impression. So this tray adhesive, don't use way too much, but you make sure you're using enough, because the inadequate adhesive can result in a visually undetectable distortion in the impression. So it's very important that you have the right amount of adhesive, and you make sure that the adhesive dries before you load the tray, otherwise it will not be effective. Okay, so when you see this diagram, Using an adhesive directs the polymerization shrinkage happens towards the tray. So basically the size of the crown can be slightly larger if it gets towards the tray, but it will not be smaller. So and this is by a few microns. It's not like suddenly the crown become really large. It's the amount of this difference that we can't really tell with our naked eye. But this is really important because the fit is improved with this method. But say if you don't have enough adhesive, so look what happens in this situation. The shrinkage is directed towards the center of the mass, which is towards the crown. So in this case, you will get a smaller crown, which will have a poor fit. So that's why, you know, using the right amount of adhesive, making sure that the tray is dry is really, really important, because if this situation happens, then we might have to redo the crown. Then impression technique, mixing sequence. First, you mix the heavy body material, you load the tray, you set it aside. Typically, assistant does this procedure. And then at the same time, simultaneously, you remove the cord, make sure everything is dry, and you start injecting right away. The sulcus is, it's about for 30 seconds, it's displaced after you remove the cord. So you want to use that time effectively. And load the syringe. All this is done before we actually start taking the impression, and then inject into the sulcus and onto the prep. So you want to make sure the entire prep has the light body, and do a few adjacent teeth. And I think you get a hang of how much is enough, or on the side of more than less. Okay, impression technique, syringing. Inject the light body material directly into the sulcus, apical to the gingival finish lines. Fill the sulcus and cover the finish lines with light body material. So typically start at the mesial and then take a 360-degree turn, and then keep going around till I fill the entire, and then take it up towards the adjacent teeth as well. So you can see the light body material here is in yellow, and you can see that it's just pink here, but you can pretty much just see yellow around where the impression is. So it's a more accurate material, so it makes for a good impression. Say you're doing a full arch impression. So in that case, it's a good idea, like if you review the cases the day before, you know a patient is coming, which means a full arch impression and multiple crowns. So you can refrigerate the impression material the night before, and it gives you additional working time. Or you could keep one syringe in the fridge, like we do our bleaching materials and stuff, so it's always ready for you. So applies to syringe material only the light body, and extends the working time, and useful for capturing multiple teeth in a single full arch impression. Okay, so double bite trays. What are the advantages of using double bite trays? So it records the exact occlusal relationship. So the way the teeth come together in the mouth, everybody has a different occlusion, you know, so it's very important that we can capture the dynamics of the functional occlusion. And, you know, you avoiding doing two impressions, upper, lower separate. And of bite I still take, but you know, that's almost 1/3 of the time, because, and then also the patient has to every time, you know, keep the impression material in the mouth and stuff. But in cases where you need to use the stock trays, then of course you do, but in most situations the double bite trays do a really good job capturing the impression. So the disposable ones are over here. And yeah, and various sizes. So like this is for full arch, this is for anterior. This is the one that I would use if there's like a canine crown or like a first premolar. Sometimes actually this is better. And this is of course with posterior molars only. Yeah, and I think this is the one that I really like if you're doing a second premolar. Make sure there's enough space for the impression to cover one tooth in front of the crown that we are preparing. Okay, so the double bite trays, they have some limitations, that is what you're talking about. So if the anterior guidance is lacking, So these worn out teeth will not provide any anterior guidance or protection to the back teeth. So in this case, the jaw is in a forward or protruded position. And why is this not a good thing? So the molars, they have relatively short roots compared to your front teeth. And they're only good at taking forces that are perpendicular on their longitudinal axis. So if the anterior guidance is not there, it's going to create sideway forces that will make it difficult to get an accurate impression. And then if the vertical dimension of occlusion is not stable, that means every time the patient bites, the relationship of the upper teeth and the lower teeth is not the same. So it's not repeatable. We mentioned that point before as well. And when you're taking an impression for combination of the RPD fixed cases, if there are complicated prosthodontics cases, you have to make sure that you're using an articulator and you're doing the stock to impressions and taking the bite and transferring it to the face bow to an articulator. Okay, so with this, we come to the end of this tissue management slides, and I'll jump right into the indirect restorations, cementation. Okay, so let me I really hope the slides are being recorded this time. I'm actually recording because the first time my slides didn't show up. Okay, so indirect restoration cementation. In this presentation, I'll talk about the steps that are involved in the final cementation of the crown in great detail. And also we're going to review the occlusion. And again, if you have any questions regarding this presentation, feel free to email me at any time. So what is the purpose of doing crowns? We want to strengthen the existing tooth, which might be weakened due to gross decay or having root canal done or large fillings. So we want to make sure that we restore the form, function, and aesthetics of the tooth as close as possible to the original tooth in the arch when it was in healthy condition. So these are the steps that are involved to get to this final restoration, which helps us achieve our treatment goal to restore the form, functions, and aesthetics of the tooth in question. Number one is prepping the tooth. So the amount of reduction that needs to be done will depend on the material that we are using. Say if it's a zirconia crown or if it's a gold crown, the measurements differ, and even for EMAX. So just make sure that you know the dimensions or you have a sense of it. So if sometimes you feel the reduction is a little bit lesser, you can just confirm with the doctor if he thinks it's okay. All right, so then after that, we have to do the final impression, which we do after cording the, packing the cord. And we have to make sure that we have a clean and dry field to capture an accurate impression. After we take out the cord, we hold the impression tray. Sorry, we take the impression, we load it, hold the impression tray in the patient's mouth all the way till it sets. After that, we take the shade with the patient's preference in mind. Sometimes they prefer a whiter shade. I warn them if the crown is too white, it will stand out, but I let them make the final decision unless their choice is way off. When the final crown comes, they're more accepting of the aesthetics. Another thing to keep in mind is that if they're thinking about bleaching their teeth, then selecting a slight whiter shade might make sense, but you know, you have to kind of take that judgment for each patient, and sometimes also their personality. Is the patient really particular about his aesthetics, or there are some patients who just don't care? And especially if it's a posterior teeth, it's not as much of a risk if it is than it is anterior teeth. But if they're not happy with the shade, we do end up sending the crown back. And also sometimes they can actually go to the lab if they have this issue with shade. And also another reason being that the shade guides that we have in the office, the 1M1 or 1M2, might not be the same shade. Like there's a little bit of discrepancy in the different shade guides. So that's another thing to keep in mind. And Yeah, so then after we've done the got the good shade, we just disinfect the impression, we remove our cotton rolls, and then we send it to the lab. If there are additional instructions, you should make sure that as much information you can give to the lab, it's good, because then they can return the crown back based on that case, you know. So it helps them make a good crown. And of course, good communication, good relationship with the lab is really important. And yeah, for some reason, if you're not happy with the lab's work, you can check with local dental society network, find out who's doing a good job in that area, and figure that part out too. And then the seating appointment. So 1 to 2 days before your crown appointment, seating appointment, just double check, confirm, have this like a system that you want to check that the crown is available for every patient who's coming in for their seating appointment. Otherwise, I think it'll be really embarrassing if they come in and they're like, oh, the crown's not ready. So you always want to check and let them know at least a day before, if not sooner, that the crown might take a little bit longer to come in, and just logistical issues. And I'm sure you guys at each office has a good system about these kind of things these days. And then we're going to talk about the cementation. So, and then what are the steps that we need to make sure that the crown has the right proximal contacts is good, the fit is good, margins are fine, aesthetics are in aligning with the patient's requirements. And of course, the occlusion is the final thing that we check. Okay, so what are the important features of a crown prep? You guys need to know this so that if there are some things that might need to be checked again, you can always just let your doctor know, like, oh, do you think there's enough occlusal clearance? Or, you know, just ask them that instead of saying that, oh, there's not enough, just because it look a little bit rude. So you just want to say that, what do you think about this, you know? So there needs to be at least 1.5 to 2 millimeters of occlusal clearance. How will you gauge that? One of the ways is to have the patient bite down and measure occlusal clearance with a perio probe. The other ways, like the pressure indicator instruments, PEP check tabs, we used to use a red sticky wax in dental school and then look through the light. So if there's a show through, and that was also a pretty good indicator of the occlusal. And it's such a straightforward thing, and most clinics have it too, right? They have some sort of sticky wax available, so it's pretty straightforward. And of course, if you're using a depth reduction burst from the beginning, you know that it will help um, gauge from the start how much of the occlusal clearance is to be done. Okay, so the axial reduction needs to be 1 to 1.5 millimeter evenly according to the shape of the tooth. So if there's a curve that's going on, you want to make sure you're cutting it in two separate planes. So we do one is that's just parallel to the tooth, and then if the tooth is curving, then we have to get another angulation as well. And axial reduction allows for enough space for adequate thickness of the restorative material. If the axial reduction is not enough, the crown will be too thin or weak or over contoured to achieve adequate thickness, which can lead to periodontal issues, and the crown might look funny. So if there's not enough material, then of course the crown needs to be strong enough. And mostly labs don't reach out to you if they find like these small, not small, but like sometimes it can be major issues. So they'll just bulk up the crown a little bit and then it'll start to look funny. The patient thinks that, oh, what is this in my mouth? It just feels a little bit more foreign to them as well. Okay. Then what is the line of draw? The line of draw is the taper of the crown prep, which should be about 4 to 8 degrees. So like about like, if this would be too much, I think somewhere around here, which is almost parallel, but it has a slight taper. And when you look from the top, so typically the good way to look at is make sure your mouth mirror is completely parallel to the tooth, and then just lift it a little bit as much as you need to just see the margins, and you have to make sure you follow it with a probe or something. Just make sure the 360 degrees you can see the margins in all the areas. If you don't, then there's a possibility of an undercut. So say there's an undercut in this area over here, you want to be able to adjust this part of the prep so that you can start to see the margin. And once that is done, only then you're ready to take the impression. So what do we aim to record while taking the impression? We want to make sure, of course, the entire prepared tooth is there, the margins are visible, and we want to do adjacent teeth, at least one teeth anterior and one teeth posterior to the prepared tooth. Of course, unless if it's the last tooth in the mouth, then a couple of teeth before that, uh, at least two teeth before that, so that just figuring out the occlusion is also important, and of course the opposing teeth which will be taken with the double bite tray. So okay, so then now once the lab receives the impression, they create a die and master cast. So of course we don't need to go into a lot of detail about the lab process, but you should know what the terminology is just in case you need to communicate with the lab about any of these things in the future. So die is a replica of the prepared tooth that is obtained by pouring the impression. And what is the die spacer? It is a colored paint on material applied to the dies that adds a desired dimension to the surface of the die and to function as a spacer. The extra thickness created by the die spacer results in additional space between the finished restoration and the natural tooth surface to accommodate the cement used for bonding the restoration. After that, crown fabrication starts. So the contour, contacts, occlusion, margin fit, and aesthetics are determined in this state, stage. And a lot of times, CAD CAM is the way that even if you guys, some of you might be even trained in how to fabricate the crown on the CAD CAM after doing all these steps. So I'll share another video that I'll put it in the slides just in case you guys want to see how to do this. So quality control. So there is a checklist of things that we need to check to determine if the crown is okay to cement. We will talk about each of them in detail in the upcoming slides. Margin fit. The crown needs to seat completely. So there is something that, of course, if we can see visually, if the margin is super gingival and we can feel it with our explorer, and some ways to confirm it is passing the explorer at the junction of the crown and the tooth and looking for gaps, and finally the radiograph is going to confirm it. So a bite wing gives a good sense of if there is any gap between the crown and the tooth. If the crown doesn't seat completely, first check the proximal contacts and adjust as needed. Usually that helps the crown seat completely. After that, we will check occlusion, the contours of the tooth, aesthetics, and the shade match. What are the steps during the cementation appointment? So first thing is that we'll remove the provisional. So you try to take it out as gently as possible. I take out the temporary crown. First, I just try with the gauze and try to rock the crown off with the fingers. And sometimes just a plastic instrument that can gently pry the crown out might also help. Otherwise, the temporary crown removal pliers, they also do a pretty good job of taking it out. Say if any of these steps is not working for some reason, then we always have our burrs handy that we can cut the temporary crown out. So then we have to make sure that we clean the preparation, like there should be no specks of temporary cement. So once you remove the temporary, clean the entire preparation up really well. Just be careful. So if the patient's crown is on a vital tooth and it's sensitive, so you don't want to go with a lot of air and water pressure. Sometimes just a wet gauze helps clean it up. So just be gentle. And then towards the end, I do try to put light air so I can make sure that there is no speck of cement left. And of course, checking with a explorer or a scaler also. Make sure that even between in the sulcus, gingival sulcus, there's not any temporary cement remaining. So then after that, once we start seating the final crown, when we are seating it, we'll try to gauge if there's um, too much of pressure. So we're going to discuss more about how we'll adjust the proximal contacts in detail in the upcoming slides. Margin fit. So it's a good idea to check the proximal contacts before checking the fit. If the contacts are too tight, then the crown will not be able to seat. So once the crown is adjusted, then it should seat pretty well if the crown has been fabricated the right way. Okay. After that, we check occlusion. Then we come to the aesthetics and color. We confirm that the patient likes the look and shade of the crown, of course, before we start seating it. But once the entire adjustment is done, then they can see the way it looks in the mouth, and they can confirm the color, the shade, the contour of the crown, and just the way it overall is sitting in the arch. Then if everything looks good, we take a bite wing to confirm everything looks fine, and then we go ahead and do the cementation. So typically try to take a bite wing before and after the crown cementation, just after crown cementation, to just make sure there's not too many specks of the cement in the gingival sulcus. And also good to do it for documentation, just to make sure that you document that yes, the crown was completely fine when you cemented it, right? You don't know what happens in the future, so just to keep that ready for yourself. Okay. So what is the function of proximal contacts in teeth? So when we were doing the morphology lecture together, I remember discussing about proximal contacts in detail. So you guys can refer to those slides if you need to. And it provides, so only if we know the location of the proximal contour, we know where the crown needs to be located. So they will provide tooth and arch stability. They maintain the teeth in their position. So that's why when a tooth is lost, this potential of the tooth to move to the missing space. And it also helps protect the gingival tissues. So gingiva fills up the space above the proximal contacts, which aids in the aesthetics of the anterior teeth as well. Okay. Sorry. Okay. So this is the part that we had, talked about before earlier in the year too. And when you look at this picture, you can see that where should the proximal contact be located. So to be able to adjust the crown, you want to know where the teeth need to come in contact, and so if you can adjust it the right way. So if you see in the molars, it's in the middle 1/3. It's 1 millimeter below the marginal ridge, and it's centered on the molars, and on the premolars, the location is a little bit buccal of the center. And then the width of the proximal contact is about 1 to 2 millimeters, and then the depth is 1 millimeter. And in anterior teeth, the aesthetics will influence position because you need to have symmetrical crowns. And if you look at the slide, you can see as we're going from posterior to anterior, the contacts are moving more towards the incisal part of the tooth, and same for the lower teeth as well. So yeah, I just added this one slide just as a reminder to see where the incisors and canines have it on the incisal 1/3, except for the distal of the canine, and the rest are all in the middle 1/3. Of course, in the last two, there's no contact on the posterior. And the proximal contact evaluation. So when we first seat the permanent crown, we start evaluating the contacts from the first step. So does it feel tight when you're seating it in, or it feels kind of okay? Then you also want to, of course, ask the patient, because if it's really tight, they can tell right away pretty much. So, and then if the patient also kind of feels it's okay, start with checking it, the dental floss. So you hold the crown on the occlusal surface, pass it through the mesial contact, distal contact. If you feel a snap, so pretty much the same way if you're doing a class 2 filling of, you guys have done class 2 amalgam and the composite restoration. So once it's complete and you're checking the contact, you can feel that snap. That's the same feeling you should get if when you're doing the crown. If it's not seating completely, then you will have open margin. So make sure you can adjust it. So that will also help with the margin fit. So this is how you can see it in the picture, how you're holding the crown on the occlusal, and then sometimes you can take the assistance of your assistant, or patient can hold it down for you in case you need that additional support. Okay, so for proximal contact adjustment, you have to identify the point of contact. Then if the contact seems tight, we need to adjust it. I go pretty slow with this step to avoid over adjustment. If the contact becomes loose, then we cannot cement it. So, and we need to send it back to the lab. So first thing we do is we identify the point of contact. Once we do that, we need to mark the restoration. Because the metal surface will be very smooth, it's hard for the marking to be seen. So we burnish the spot on the metal where where we estimate that the contact is going to be tight. So again, the knowledge of the anatomy will help. If you're doing a posterior tooth, you want to have the middle 1/3 of the tooth area marked, so you can see where it's going to be feeling tight. Okay. So we mark the contact with articulating paper, occlude, top high spot indicator, and then we'll adjust the contact with, try to use a very, not a coarse burr, so that it's pretty smooth, and I don't require a lot of polishing, again, to avoid the crown from becoming loose. And then once the restoration feels fine, it feels like with the floss you've checked, you're getting the snap that you're supposed to with the mesial and distal contacts, and we go ahead to the next step. So we'll just take a look about the articulating film. So basically the way that it works is that you want to even put it between the teeth, but I sometimes just try to get that stain of the articulating uh, paper by rubbing it on the crown. And another way to do this is if you have a Sharpie, or if you have like those staining pencils, that can also be used instead of the articulating paper. And here you see the occlude spray is being used, and the contact. So if there are adjustment required for metallic restoration, we use the this is the system that we use. We have the Burlew wheel, then we have the Brownie and the Greeny wheel, and then the buffing in the end. And then if you're adjusting for ceramic restoration, first you want to use a medium or fine coarse diamond, and then we want to use the dialight wheels to do the uh, polishing, and you want to go through each of the steps and give it enough time to make sure that the end result is pretty well polished. And yeah, just if you're doing the proximal contact adjustment and you feel like you're almost there, like just keep that extra amount for the polishing. So if you really remember to make sure that you're not over adjusting the proximal contacts, because loose contact will not be good for the tooth in general. I mean, you always have to send it back, because then food will get stuck, will cause gingival issues. So it's a big no-no. Okay. So I'm going to be, and the next slides that I've done already works on these parts. So yeah, see you in the next part of the segment.